kakayaka kako. Welcome to the WASSP Committee meeting of Monday, March 9th, 2026. It is now 10:04, and mahalo for the late start. We kind of clearing all the cobwebs, literally, figuratively. I'm Shane Sinensi, your committee chair. Mahalo members for taking the time to attend this meeting. As a quick reminder for members of the public to please silence your cell phones or any noise-making devices. Members, in accordance with the Sunshine Law, if you're not in the council chamber, please identify by name who, if anyone, is in the room, vehicle, or workspace with you today, and minors do not need to be identified. Please see the last page of the agenda for information on meeting connectivity. Joining us this morning, we have Committee Vice Chair Gabe Johnson. Aloha and good morning.
Aloha and good morning, Chair, Council members, community members. There's no testifiers here at the Lanai District Office. I'm alone on my side of the office with my snoring dog and my chirping birds outside. So I'm here and ready to work. Mahalo, Chair.
All right, great. Welcome, Hoku. Also joining us in the chamber is Councilmember Kawanoi Batangan.
Hey, good morning, Chair.
Morning. Thanks for being here. Also in the chambers, we have Councilmember Tom Cook. Aloha and good morning.
Aloha, good morning, Chair. There's currently no testifiers in the Kihei office, but we have staff on standby and looking forward to your meeting.
Welcome, Kihei office. I don't see Chair Lee. Is she on? Oh, she's logging on. Okay, we'll come back to her. Joining us in the chambers, Councilmember Tamara Paulton. Aloha and good morning.
Aloha kakayaka kako, streaming live and direct from the council chambers.
Mahalo for being here. I presume Member Rollins Fernandez is in Molokai or somewhere in the world. She'll let us know.
Aloha kakahiaka chair, aloha kakahiaka kako. My Molokai nuia hina, with a background from Lanai.
Oh.
I'm at my private residence. I have my daughter with me. She's under the weather, so if you see me speaking with anyone, that's who it is. And there are currently no testifiers at the Molokai District Office. Mahalo, Chair.
I'm from the Cedar Room at Lanai Hotel. Welcome.
Yeah, that's it.
I do see Chair Lee now. Aloha and welcome.
Aloha, Chair. I'm here alone in my workspace. I'll be here today because my kitty is undergoing surgery today, so I have to be on call for her. But I am on call for you as well. Thank you.
Okay, mahalo for being here and prayers for your little kitty. Also joining us in the chambers is Member Sugimura. Aloha and good morning.
Good morning, aloha. Nice to see you, and I hope all of you had a great weekend.
Thanks for being here. I do not see Member U'u Hudgens, but I'm sure she'll join us in a little bit. From the administration today, we have Acting Director of Human Concerns Online for our first item. And then for our second item, we have the Director of the East Maui Water Authority. From Corporation Counsel, we have Ms. Yukari Murakami. Aloha and good morning. We also have WASSP committee staff with us this morning. Good morning, everyone, and welcome. Okay, members, on today's agenda, we have two items. The Continuum of Care for Substance Abuse, WASSP 1 Parent 17, and the Operational and Budgetary Review of the East Maui Water Authority, WASSP 1 Parent 18. Without objection, members, for WASSP 117, I'll be designated Chief Executive Officer of Maui Behavioral Health Resources as a resource under Rule 18A of the Rules of the Council because of her expertise on Aloha House, medically monitored withdrawal management program. Any objections?
No objections.
Ms. Nicole Hokoana, Kalamai. Staff, do we have any testimony this morning?
Chair, no one has signed up to testify at the beginning of the meeting. Would you like us to do a last call?
Sure.
If anyone would like to testify, please come up to the podium or raise your hand on Teams. The countdown is 3, 2, 1. Seeing none, Chair.
Okay, mahalo. I'll now proceed with our first agenda item. Members, today's first agenda item is Continuum of Care for Substance Abuse. Aloha House is part of Maui Behavioral Health Resources, and we have Ms. Hokoana here today, and I believe many of you had attended the groundbreaking or the opening of the new dormitories. Aloha House was established in 1977 to provide sober living accommodation for adults in recovery. Their continuum of care to treat substance and alcohol use disorders has grown to include a medically monitored withdrawal management program. Established in 2000, Aloha House Inc.'s medically monitored withdrawal management program aims to safely manage subacute withdrawal symptoms when an individual stops using substances or alcohol. It also introduces and connects participants to treatment options, supporting their continued recovery journey beyond the initial medical stabilization. And so to learn more about this program and other care options, we have Ms. Nicole Hokoana from Maui Behavioral Health Resources with us this morning. Again, mahalo for joining us, and you now have the floor.
Good morning. I was actually trying to move this farther away from me. Aloha kakahiaka kako. Good morning, Chair, Vice Chair, Council members, and Council Member Sinensi for inviting me to speak. My name is Nicole Hokoana, and I am the CEO for Maui Behavioral Health Resources, which includes 3 agencies. We'll be talking about Aloha House today, but our sister agencies also include Malama Family Recovery Center, as well as Maui Youth and Family Services. So today I wanted to share with you guys a little bit. I took this as an opportunity to share and educate you guys a little bit about what we do. In my role as CEO for the last 2 years, I've really begun to realize that we're kind of tucked away, and not many people know much about treatment services and some of the unique services that we provide here on Maui that is really unprovided throughout the state. So Aloha House has been in community since 1977. We serve primarily our local community here. We've been a safety net providing the only residential treatment program here in Maui County that is accredited both nationally as well as within the state. We maintain licenses, and this is for many, many years. And I think it's an important part of being a provider is being accredited and maintaining licensure. So we also provide a medically monitored withdrawal management program. And it's also unique in the state. So what happens, I'm gonna describe a little bit of our workflow, but we've been working very closely since the year 2000 with the emergency department. So when people go to the emergency department and they're detoxing from substances, the emergency department will not want to admit them unless there is a medical condition, an acute medical condition that requires admission. So our partnership with Maui Memorial or Maui Health started in the year 2000, and what happens is the ED will conduct a physical, do a toxicology screen, order medications that might be needed in order for the patient to be able to detox a little more comfortably. And then they call us, they let us know that they're gonna be transferring a patient to us, as long as that patient consents. So with that consent, we'll drive to the emergency room, we'll pick up that consumer, we'll go to the pharmacy, pick up their prescription, and we'll bring them onto our campus. And one of the reasons this this is such a unique, it's a unique partnership, but also we have registered nurses 24/7. So we're really able to care for a subacute population that I don't know that there's any other organization in the state that does something similar. And we've been doing it for so long that this is kind of the only way we know how to operate. But one of several benefits is that we reduced the people in the ED, right? Reserving care, ED care for those that are in most need of it. So we're bringing them onto our campus. We're exposing them to our campus where we have people there that can engage them in treatment, because detox isn't treatment. Detox is just the first step. We're able to offer medications that are prescribed by the physician to stabilize them medically, and then be talking to them, counseling them, hey, are you ready for treatment? And then, of course, our goal is that they'll say yes, maybe now's the time. And our campus is there, right? So it's just a couple feet away. We can transfer them to our residential program. And we just have the best, it's just the best likelihood that someone will give treatment a try. And the first 2 weeks of being on our campus, they're most vulnerable of leaving what we call against medical advice or against staff advice, but it is a voluntary program. So at any rate, that's some of the benefits of having a medical detox with this nursing capability. Also, we offer on our campus, we have a mental health stabilization program. So after or while they're detoxing, if they need sort of psychiatric medications, we can connect them with APRN RX. We can get them those medications, because often it's co-occurring. So we know people are struggling with maybe some mental illness, they have anxiety, they may have depression, they also have a substance use disorder or alcohol use disorder. So we're able to treat any and all of it. And if they're not quite ready for residential because they have a mental health concern that's sort of a barrier, like we need to take care of their anxiety a little bit before they can really engage in treatment, then we can put them into the mental health stabilization program for 10 days, stabilize, and then try and get them into residential. So our campus is super unique. Having the medical staff, having psychiatric services, it really is, it's a really great program. And we're very committed to, trying to keep these programs open and available here on Maui. Programs like this may have existed in the past on other islands, but it is cost prohibitive because of the nursing. And we all know how nursing costs have risen over the last 5 years. So I wanted to provide this chart just to sort of inform the members, and also also the broader public about what happens over time when reimbursements remain flat while costs go up. So you might be able to tell a couple of things from this chart is, we were about breaking even around COVID, 2019, 2020. And maybe like a lot of organizations, we expected the cost to go down. We expected housing costs that rose to be temporary. We definitely didn't plan for wildfires. We didn't anticipate that the exorbitant rise in costs over time. And so what the situation Aloha House is finding itself in, which is part of what I wanted to share with you guys about, is that we have flat contracts with the, flat meaning like our revenue doesn't change over time. We have contracts with the Department of Health, Alcohol and Drug Abuse Division. We've received the same amount of funding for 10 years, more than 10 years. And I'm very grateful to the county. We've received support for our residential program, for our medical detox from before I was ever at Aloha House. So I'm very grateful to the county. And there's a lot of really valuable nonprofits out there. So I never want to, not be grateful or not appear grateful, but we do typically receive the same amount over time. And so it doesn't help us to meet the rise in inflation. Also, a big struggle for us is insurance companies. Aloha House is about 85% Medicaid funded. And so that was the other concern that I wanted to, just bring awareness to. Because the big, beautiful bill, we're starting to see impacts. We know that it entails major Medicaid funding cuts. What that looks like today for us, what it looks like is we're providing, people with behavioral health issues, you need to help them now. Like, the window of opportunity to really, that window of readiness, that motivation to change, it opens and closes, right? And so you have to catch it when it's open, which means we can't wait 2 months for your PCP appointment to get a referral to Aloha House. And that's why we work so much with the emergency department, because people are going in there, they're not feeling well, they're going in there, and we can try and get them in, get them that physical, get them the prescriptions they need, like right away. But having said that, what we're seeing with Medicaid now is, the work requirements. So questions about previous work history being a barrier. We're seeing requirements for citizenship, proof of citizenship. So that's your birth certificate, your passport. We're seeing Hawaii residency requirements, so your license. A lot of these folks don't have documentation. If they're not from, if they're from the continent, then it can take months for us to be able to retrieve those documents. Our staff are very adept with Medicaid and the MedQuest office. We can get people that were formerly on MedQuest re-enrolled if those documents are already at MedQuest. But if they're not, then it can take 3 to 4 months to get people enrolled. So that we're just seeing a slowdown, right? We can't admit people right away if we can't get them enrolled in MedQuest. So Medicaid issues, I don't know if you guys remember, I think around January, there was like this sudden, I believe it was an executive order, but there was a block on SUD, substance use disorder and mental health block grants. It happened in the morning, and then by the end of the day, it was rescinded. And we're like, whew. Because the block grants fund the State Department of Health. And then the State Department of Health collects, receives these big block grants, and they distribute it to the different counties. So, we don't know what's gonna happen, but, that's a portion of our funding, that maybe at a whim, may disappear. So we also know there will be a future reduction in the ACA marketplace subsidies, and there are limits on state provider tax use, which I don't know a lot about the fourth bullet, but so I'm gonna move forward. So for us, what this means is fewer patients will be able to get on MedQuest, get enrolled, re-enrolled, reduce Medicaid coverage. For our residential program that relies on, from ADAD, getting block grants, maybe there will be funding constraints. And then in our outpatient programs, there may be fewer people that are covered due to ACA subsidy cuts. So fewer people that have insurance, right? So we're looking at, if Medicaid is like 85% of our funding source, with government contracts, including the county, being about 15%, these are substantial concerns for us. And I would imagine all healthcare providers, especially those that serve the MedQuest population, that serve as sort of as the safety net. Safety net programs like ours are going to be impacted by the big, beautiful bill. So declines in Medicaid enrollment, shrinking block grant allocations, reduced ACA subsidies, and what we feel right now is increased financial pressure. And this is kind of national, but here in Hawaii and definitely here on Maui, I think we all know we're living in a very high stress time where whether it's the grocery store or our cost of rent, our cost of housing, all of it is really expensive. And if you think your grocery bill went up, imagine like our campus, we're feeding, 50 people every day, 3 times a day. So our costs have also gone up. And so as an organization, we have our homework to do also. Insurance companies, I have a teacher background and I have a social worker background, and I had no idea what it would be like working with insurance companies whose, some of their staff members, provider contacts, for example, like their main job is to evade us, is to not write us back, is to not answer our phone calls, not return phone calls. We get so busy as nonprofits that we fail to keep tracking it, or have a dedicated position, but that's kind of what you got to do, right? So that's been some of the learning curve for me, is understanding that this is what it is. This is the game, right? And if you want them to pay, you have to really dedicate time, effort, and energy towards communication with insurance companies. And so we're really trying to do that to get an increase on our rates of reimbursement that are old. We have old contracts with insurance companies, so we need to get those revised. And we need to be better advocates for ourselves in that arena. Having said that, it's, we still have the big, beautiful bill and all of the challenges that is implied with that. So anyway, this is about the conclusion of my PowerPoint. These are our challenges: unstable, less stable year-to-year funding. There can be reduced access to care because we're unable to get people onto MedQuest. Definitely operational strain on detox and inpatient centers, and there may be increased wait times, and which increases the risk of relapse for people that we're trying to serve. So these are some of the risks and challenges that we as providers are trying to keep our eyes open for and prepare for. And I thought today, since I had this opportunity to share with you guys a little bit about what we do, I thought it was a good opportunity for you to understand, like, as a healthcare provider dependent on MedQuest, we need to diversify. We need to have a lot of strategies, but also, like, we need our county and state contracts to increase, right? To help us to meet the inflation of the last 5 years that we thought would go away, but never did. Quite stubborn inflation we're seeing on Maui. And it just made the work all the more challenging. I don't know if anybody has questions or how this works next, but thank you all.
Mahalo, Ms. Hokoano, for that presentation. Thank you. Before we go to Q&A, we'll take any testimony. I see JC coming down.
Aloha, Luna Ho'omolu, Senetsi,
Aloha.
Oval JC Law, Kula Uka Wako Ahupua'a. Thank you for being here this morning, and Ka'aha o Kekalana, and the new guy down there. When I saw this on the Papakumu Mana'o, the agenda, other than thinking this would be a very relaxing and comfortable class because you're the kahu, the teacher today, I just wanted, I had some things on my personal life, and I try to relate it to this, the presentation. And I could see why they made Nicole the CEO of the company, because that was very informative and it was a nice presentation. So the thing that popped up in my mind with this, she started saying about Quest, and I think there's something called the coordinated entry system. So when anybody, and like identification and passports and all this stuff, my concern was that if they're, I'm probably on the entry system too from when I was in the Salvation Army's care over there in Kahului. My concern is that they put you on a computer list and then who's looking at the list. So, yeah, you guys know where we're going with that with this past week's events. And I'm wondering personally if I could, so I'm sorry I missed when you guys built the new housing up there, because I would like to have seen that. I guess nobody's really allowed to go just walking around in there. So I've considered trying to approach the gate. I'm gonna take a trip up to north side of the mountain. But yeah, I was wondering if number one, if I could use your address to get an ID card, and number two, if I could look on the computer and see what they got about me on there. Thank you, Shane, and I saved the rest of my time for the Hawaiian peoples.
Mahalo, JC, for your testimony. Any questions for JC? Seeing none, thank you. Are there any more testifiers?
Chair, no one else has indicated a desire to, no one else has signed up. So we'll proceed to last call. If anyone in the audience or on Teams would like to testify, please come up to the mic and begin your testimony. Or use the raise your hand function on Teams. I'll provide a brief countdown. 3, 2, 1. Seeing none, Chair. No one has indicated they wish to testify on this item.
Thank you. Any objections to closing public testimony at this time for this item? Okay, thank you, members. Okay, members, I would like to open the floor for questions and comments. Each member will have 3 minutes for the first round and then 3 minutes for any additional rounds as needed. And we can go ahead and start with Committee Vice Chair Johnson for your 3 minutes.
Okay, thank you, Chair. Thank you, Ms. Hokuana, for joining us today. And I just want to first say thank you for the work that you do. This kind of work is really important to our community, and I just can't thank you enough, which is why we try to fund you as much as we can. So your presentation, it was really eye-wide opening for me to see that all the struggles you're dealing with the recent cuts to your funding. We do have some interesting grants out there. I'm curious if you've applied for it. The Farm to Family, it is the Local Nutritional Security Initiative, where you can apply and to get funds from the county to pay for locally grown food to feed your guests. How does that, have you guys applied for that grant?
No, I did not hear of it, and something food related likely wouldn't be on our radar. So thank you for sharing about that funding opportunity.
Yeah, it was one of my priorities last year to help folks who are feeding people such as yourself, preschools, et cetera. And we hope, this year the department puts it in again for this upcoming budget. So there is funds out there, Ms. Hokuana, which is, I just wanted to bring that to your attention.
Thank you.
You can email me and we can try to give you some details later off the floor. But really, I want to move forward to that SUD block grants, and that there was a chance they were getting cut, and you get that fund from the state.
Yeah.
Can you explain is there a number attached to that? How much are you getting from the State Department of Health for that SUD block grant?
Yeah, we've Aloha House, so we have 3 agencies, right? But Aloha House has received about $500,000 a year for at least the last 10 years.
Mm-hmm.
That's what we receive for our continuum of care. So our continuum of care at Aloha House, it starts, so withdrawal management is often the entry point, and then we have residential, high-intensity clinically managed residential program, which is about a 45-day program, which is what we hope people after being in our detox will transition to. From the residential program, we have an option for an extended care, also known as like day treatment. It's a little more supervised than completely stepping down to intensive outpatient. And then from intensive outpatient, we have outpatient services. So these are levels of care. And from Aloha House Residential, the step down into outpatient levels of care, we also have clean and sober housing. So we try to get people to stay within our clean and sober housing. So that $500,000, it goes to pay for primarily it pays for the housing on the back end. But we can use it in, I mean, I don't know if I should finish explaining, but really quickly, we can use it anywhere in our continuum, but because we can charge insurance for the detox, for the residential, for the intensive outpatient, we try to use insurance, MedQuest charge insurance for those types of activities, and then we save our state funds, our state block grants for what insurance won't pay for. So insurance won't pay for transportation, care coordination, housing, and outpatient, which is like continuing care after you've kind of graduated from most programs, and maybe you see a counselor once a month and you go to class like 2 hours a week or something. So insurance won't cover that. So we try to use our state funds for what insurance won't pay for and insurance for what insurance does pay for. Hopefully that makes sense.
Thank you for the response, and I'll wait for second round, Chair. Thank you so much.
Okay, mahalo, Vice Chair. Sorry, I forgot to introduce Member U'u Hudgens. She's been sitting patiently. Welcome.
No, sorry, I came late and in between Ms. Hokoana's presentation. Hold on, I'm just trying to write down what she said last so I don't forget it. But hello, good morning.
Hello, good morning.
Good morning.
Next, we'll go to Member Batangan, and then we'll just go down the line. Member Sugimura.
Thank you, Chair. Thank you for being here.
Thank you.
Does Aloha House have any service contracts with the county, or do we only give grants?
I believe grants.
Okay, so it's not multi-year, it's single year.
Single year.
And
Well, I mean, with the Department of Human Services, it's usually 2 years, right?
oh, you do have multi-year grants through the department, okay.
Yeah, human concerns.
Okay, and with those, is there no, service increase over time? Like, how come your revenue has remained flat?
I mean, not typically. Typically, county grants, state grants, I mean, there's a lot of really valuable and good nonprofits out there, and there's only, so much money to give away. So I totally get that, And so mostly our grant funds kind of stay flat because that's how I'm guessing the department is able to meet the needs of various organizations. So it's hard to give increases. Sometimes we get a little bit of an increase. I don't know if there's extra monies or, so sometimes we do, but mostly grant funding, continuous kind of grant funding like we get from the state or the county, mostly it stays about the same. And same can be said for the state, for ADAD, right? They're funding treatment programs in the state. So it's hard to, I guess, justify or have the additional funds, right?
Okay. But if your operating costs are increasing, but
Yes.
the grants from the county and the state are staying flat, then every year there's a bigger delta.
Yes.
I guess that, to me, would be the justification for an increase if
Absolutely.
we had to have.
I would love an increase.
Okay, thank you.
Yes.
That's all, Chair.
Mahalo, Member Batangan. And members, we also have Acting Director Jessica Kraus. Should you have any questions for her, I believe she's online. Member Sugimura?
Thank you. Thank you very much for being here.
Thank you.
And all the information. So Tracy
Yeah.
Fujita is still with you.
Yes.
Lucky
yes.
you. She's very
yes.
good.
Absolutely.
Yeah. And you said that wildfire impacted you. So what happened there? Did you get more clients or what was it?
Well, the wildfire contributed to the cost in care because so much money came into community. People like counselors, licensed counselors, nursing, registered nurses were being called out to serve in Lahaina, and they were paying above and beyond what we pay. So in order for us to kind of compete and keep and retain our staff, our licensed counseling staff and our nurses, we had to increase their salaries, and not what everybody else was paying, but it just costs went up. So we had to become more competitive, or else people were gonna go work out in Lahaina.
Okay.
So that contributed to our rise in costs, but also the food, and then just utilities and things like that, of course.
Everything.
Goes up.
So you
Has
also
gone
said
up.
85% you are Medicaid funded. And so with everything that we're seeing with the federal government now, is that already impacting you or?
Well, it's impacting us because MedQuest is getting more strict with requiring the proof of citizenship and proof of Hawaii residency. So the MedQuest office is starting to implement the changes,
with
those
the
requirements.
big beautiful bill or whatever.
Yeah.
Kind of requirements.
And I think there's a work requirement as well. There's a work component of the big beautiful bill. And I know that because we also bring patients in from MCCC. And sometimes when we're trying to admit those members that are coming out of jail into our facility, some of the MedQuest is, putting up barriers and needing work, kind of like their work histories. And we're like, okay, but they were in prison, so they don't have a work history right now. So we're just seeing some different kinds of barriers that are related to that just delay people being able to get enrolled in MedQuest. And in turn, that results in us not being able to serve them in a timely manner.
Did you apply for a GIA grant with the state?
We did.
You did?
Yes, so we did. For our detox specifically, we applied for a grant in aid. And it's because the nursing cost, 24/7 nursing is expensive. So we're hopeful that we can, advocate for increases to our contracts, also apply for some one-time funding, like grant and aid, and then finally, do more with insurance companies to get them to pay more and pay their fair share.
So that must be a universal problem.
Oh, yeah, I'm sure.
Okay. Grants and aid will not be awarded till the end of the legislative session, so you're going to have to hang on for that.
Yeah.
But would love to advocate for you if you need. Thank you. Sorry I went over.
No, mahalo, Member Sugimura, and I just wanted to add that at NACO, our friend Irene from Minnesota, she kind of mediated a discussion about Medicaid and SNAP benefits. So we did get the information. We'll post it on to today's meeting.
Thank you.
Granicus, thank you.
Thank you.
Member Polton.
Thank you, Chair. Thank you, Ms. Koana. I was wondering, when you were talking about people coming out of jail, they're coming out of jail addicted to substances?
Yeah.
Okay.
So, yeah, we have the Maui Drug Court contract.
Okay.
But then also there's I don't know, although, there's pre-release if the reason you've been in jail is because,
What
substance use related.
substances, are you seeing mainly that you're needing to detox from?
Well, we see all of it, but meth is still the primary drug of choice, I would say, but meth is now often lined with fentanyl. And so that's where meth can be. So people don't realize that they may be ingesting fentanyl. They think they just took a hit of meth, but fentanyl is being added. So there's a lot of polysubstance use, and that's why we need the emergency department to do the tox screen so we can make sure that we have the appropriate medications to detox them safely. Because they may say, and they're also poor reporters often of, you know, what they've taken or what they've done. But the tox screen enables us to do it safely.
And then, what is your success rate? Are you tracking that?
Yeah, I mean, our success rate is kind of typical. I would say that of the people that come into detox, which is not treatment, it's an effort to safely detox and convince them to stay. We have about, I would say, low 70, high 60% of chance that they're going to come to residential. So a little bit more than half will say, okay, I'll come to residential, I'll give it a try.
And then, in terms of how many people that you could, in theory, treat in a year and the budget for that, do you have those numbers? Like if you were pumping out max capacity for the year and the budget that would take, and then the shortfall in that, or the delta?
Well, it's hard to, that's a really great question. It's hard to answer that because so much, I mean, our work is so complex. People
It's
need
not a
to,
standard formula.
yeah, and people change their mind. We can do all the work to bring them in. We can detox them safely. They
I
can
guess
agree, and then they leave.
The average of the last 3 years, what was your capacity or so like?
So our residential facility, typically between detox and residential, we serve about 400 individuals. And then, but again, like
annually.
that's just the beginning, right? Because residential, you know, you might detox 3 to 5 days, then you go into residential, right? If all is going well, you go into residential, depending on your insurance, you're in residential 30 days to maybe 45. If we can justify an extended stay, then we try to get you up to 60 days. And then after that, you step down to outpatient, more outpatient services. But, you know, like 45 to 60 days of sobriety is not that long. And then once you go to outpatient and you don't have the same 24/7 supervision, you know, we want you to enter clean and sober housing, but, you know, you're not supervised after classes. So, you know, it's a relapsing disease. So our participants require a lot of support over time.
I'll come around next time.
Okay.
But my question would be like, do you have a dollar number that you're gonna testify during the budget hearings?
Oh,
Okay.
yeah, well, I know my gap is about 500,000 right now. That's our gap.
Okay. Next, we have Member Rollins Fernandez, followed by Member Cook.
Mahalo, Chair. Aloha, Ms. Hokuana. Mahalo for your presentation and for answering our questions this morning. I guess I can follow up on that question with the 500,000 gap. Is that like all in programming, or are you able to provide us a little more detail on what consists of the 500,000?
Yeah, I would say it's payroll. It's the payroll, it's the cost of 24/7, a variety of different positions, 24/7. Most importantly, our nursing staff, that after the wildfires, we did increase their pay to try and retain nurses, because it's just so hard to find, the professionals we need to deliver this work. So yeah. So payroll. Did that answer?
Yes.
Oh, okay.
And then my other question I had was, so in following up with Member Paulton's question about, success, would you share with us like some of your criteria or measurements, matrix of how you determine, your success rate?
Yeah, success is hard to measure because every day that someone stays in recovery is a little mini success, right? And so for us, success is when someone decides to go from detox into treatment. Yay, that's the first step. Continued success means they'll transition from our residential program into an outpatient setting, stay in clean and sober housing, reintegrate into work, move out into community. We do have clean and sober housing available that in community, we have apartments where our classes are, but then we also have in community homes where they're really out of sight. They can really get out of sight, out of mind. We can house them for up to a year. Many people stay with us more than a year because it's just it's hard to find housing in community, just there's lack of housing, right? So people end up staying with us longer than we can really afford to keep them. And then we need to also provide for the ones that are more acute and early in their recovery that may be transitioning from residential. So, success is every day, and also success is at the end when someone is actually really graduating, truly like leaving Aloha House altogether, leaving a clean and sober housing for reintegration with family, or, maybe a affordable, rent somewhere, or, independent of Aloha House.
Mahalo. Mahalo for mapping out like what individual success would look like for a participant. And then maybe in the next round, like how you measure organizational success. Mahalo. Mahalo, Chair.
Okay. Mahalo, Member Rollins Fernandez. Next we have Member Cook, followed by Member Uu Hutchins.
Thank you for your presentation and for your passion and care. How big is the need? And broad strokes, my questions, just like how much of the need do you feel that Aloha House currently is satisfying or meeting, and how much of the, how many people are not receiving service? I know this is real estimating. I'm just trying to get a feel for that. And then how many people repeat? And that's kind of I just want to try to put it in perspective. I really respect what you're doing, and I'm supportive.
It's really hard to tease out the answers to those questions. Nationally and even on Maui, I think there is like a set percentage of treatment beds that are needed, and not nationally, not on Maui, not in the state are those treatment beds available. But part of the problem is not just having adequate beds. This is the nature of our work. We're working with people with behavioral health conditions who change their minds, who have mental illness, who want to get sober, then say, no, I don't want to get sober anymore. It's a relapsing disease. So I feel like we have, like, the bed spaces are adequate, right? Like, because it's a relapsing disease and people change their mind, and we may work really hard to get someone into treatment just to have them 2 days later say, oh no, never mind. I'm good. I don't need treatment.
No, thank you.
So it's really hard to tease out like how much is needed, because we know more is needed. It would be great, but we need to match it's the readiness of the consumer, right? How many people are ready? I always have ohana at Aloha House, almost always. I know people that are in treatment, and it takes a long time for them to be ready to get there.
So thanks. So you answered. So as far as beds go,
I feel like the beds are adequate. It's, the readiness of the community, which is always a struggle, and the fact that you need to have these services available when they are ready. So that makes fee-for-service, when you can only get paid when you have a consumer in front of you or sleeping in your bed, right? Like, there's costs of care that are unreimbursed, because sometimes there isn't someone sleeping in that bed, or they change their mind. And so it makes for difficulty with the fee-for-service contracts that we have.
okay. How many What percentage, or is it often that you have members from the unhoused community?
Yes. I mean, we're serving about 50% of people that come into Aloha House are unhoused. And so one of the benefits of a contract that Councilmember Gabe Johnson really helped us with, we call it enhanced care. What we've really been trying to do is get people document ready when they are at our residential program, get them document ready, because it helps them down the line. Even when they get to clean and sober living, they're able to get a job, right? If you don't have your license, you can't get a job. So it kind of, it all scaffolds.
Yeah, thanks, my time's up. And
Sorry.
I think I'm super supportive of that also. That is a key. If they can't get their identity back and they can't get back on track,
Yes.
then it's hard. Thank you, Chair.
All member Cook. Next, we have member Ua Hutchins, followed by Chair Lee.
Thank you. I was going to ask about the gap in funding, so I'm glad you already answered that. But if I can ask, not necessarily just about Aloha House, but, some of the issues we have just in the community, how do you think we can better prepare people to be able to receive treatment? And their families.
That's a really hard question.
There are a lot of things I think as a community, as government, we can throw money at that solves problems, but I don't know if this is one of them all the time.
Yeah.
Granted, the money is gonna for sure help, but you don't have to answer that now if it's too much. And then my other question was, of course we're happy to support Aloha House. What else do you think we could support before people go to Aloha House that can help aid in their sobriety? If you have any thoughts about that.
Okay, so the first question was a really hard question to answer because I think it doesn't have anything to do with treatment. I think it has to do with prevention.
Okay.
And our keiki and our families that are stressed and can't afford this and that and want to give the best lives to their kids but don't have the means to do so. I feel like it's really important to get on the prevention side. The answer is never needing treatment, honestly.
Yeah, for sure.
Right, healthy families, that's the answer. If we can strengthen families and make lives easier for them here on Maui, then we're not going to see young adults and adults in treatment, right? So the people we see in treatment are often have lived lives of trauma. They've experienced trauma. They've been in foster care. They've had parents that, have used, and I'm very fortunate because I also oversee Maui Youth and Family Services, and we've done almost 50 years old as well. We've done foster care. We've worked in keiki mental health for many, many years, and I have the great privilege of overseeing a safe house for girls ages 12 to 17 off Baldwin Avenue, and programs like that. I mean, it changes lives, it changes trajectory
100%.
Because kids are removed from a unsafe environment and they can stabilize and start to think about a future. And, but again, like these are kids in foster care, but not all, it's a small portion of kids, right, that are in foster care. But I mean, I think helping everyday families, it's the everyday families, which are the bulk of the families, right? The everyday families that are struggling. I would love to throw money at that.
Exactly.
Childcare. Yeah, housing.
Thank you. I appreciate that. Thank you for that answer.
Honorable Member Ua Hutchins. Next, Chair Lee, for your opportunity.
Thank you, Chair. Good morning, Ms. Hokoana.
Good morning.
Thank you for your work. I know exactly what you go through. I was wondering how many, if you break down the men and women, how many men do you help and how many women do you help?
Well, because Malama Family Recovery Center is for women, Aloha House has has a greater ratio of male to female because we have Malama for women, and we believe that gender-specific treatment is what's most appropriate and best for women. So at our Aloha House campus, I would say it's a fourth is women and 3/4 are men. And then we try and get them into Malama.
Okay. How many of your clients actually work, have income from a job?
That's a good question that I am not prepared to answer. They definitely, I mean, coming into Aloha House, I would say 0. No one has employment, right? They're getting enrolled or re-enrolled on MedQuest. We're trying to get them through treatment. Once they get to outpatient, we try to get them into work.
Okay. My time is very limited, so I have to move on to the next. But as
Yeah,
you
no
know,
problem.
we're pretty much in closely related fields. Our nonprofit is more housing and not wraparound services. But we find that there's a high rate of recidivism for a couple of reasons. One, a severe lack of self-esteem is a huge issue, more than the addiction itself. And the other thing is a lack of ability to compete in the marketplace. So do you have an outlet where, whether it's with the school, DOE, or the college, where you can direct people to be trained for an occupation?
I would say yes. Once consumers are in our clean and sober, we're trying to find out whether they need some upskilling, whether school is an option for them. Some of them go back to school. Some of them prefer to get back into work. To speak to your comment on self-esteem, I would say absolutely. Like the broken spirit is the reason people turn to addiction.
Exactly, that's what we experience as well. So we're going to be focusing more on that end. But I do sympathize with you trying to, because you're dealing with everyday costs.
Mm-hmm.
And as you can see, our council is very supportive of your program. So the more specific you can be, the better in terms of how much and for what you need it. Thank you.
Thank you.
Hello, Chair Lee. I just had a couple follow-up. At the beginning, you mentioned that before they can receive treatment, they have to go to the detox program. And in that detox program, you have nurses and physicians that can prescribe medications. But we understand that there's more advanced medications now that can help some of that they've been on whatever drugs. But are those drugs more expensive? Like I think, is it Suboxone?
Suboxone.
Or some of these other ones that can really help cure or help them get them stable enough so that they can go through treatment.
Right, so I think you mean Suboxone.
Suboxone.
And methadone can be prescribed, and what it does is it provides a small amount of a stimulant that's similar to the opioid so that it reduces cravings and urges and allows them to settle into day-to-day life. And so some folks actually remain on Suboxone or these kinds of prescriptions for many years because without it, they get these urges that are really, really difficult to have self-control against. So yeah, at Aloha House, we're able to connect them with a psychiatrist or APRN, prescribing APRN that can, if they have an opioid addiction, they can get started on Suboxone while they're at Aloha House. And
only the psychiatrists prescribe these
Yeah.
certain amount of
Yeah,
these prescriptions?
yes, you need a prescriber, someone that's comfortable with psychiatric medications.
Do we have enough on island?
I wouldn't say we have enough, no.
But we have,
We don't have enough medical providers,
but we have
period.
access to those.
But we do have access to prescribing physicians or the APRN RX that can prescribe Suboxone, which can make it makes all the difference in whether someone with an opiate addiction stays in treatment or leaves, because the urges are just so strong.
But are these medications covered?
They're covered by insurance, but if the individual does not have insurance, I would say for a month of, I mean, it might depend on the insurance coverage, but I want to say it could be up to like $800 for a month of Suboxone. So it's not affordable. And so we need that MedQuest coverage for prescriptions, detox prescriptions.
Okay.
Detox and then, the medication-assisted treatment.
Okay, thank you for that. Members, any need for a second round by a show of hands? I know some of you had, Member Sugimura, and then Vice Chair Johnson, and Member Rollins Fernandez.
Okay, thank you. Just one quick question. Veterans, so is there special coverage for veterans?
Veterans, TRICARE is the coverage for veterans. Yeah, so it's a little bit different, and we are working with veterans through TRICARE, but we're also trying to see if we can, I don't know, get a special contract in place or something rather than fee for service. But yeah, TRICARE is the insurance coverage for veterans
From the federal government?
from the federal government, yeah.
Thank you. Thank you, Chair.
Vice Chair Johnson, followed by Member Rollins Fernandez, and then Member Polton.
Thank you, Chair. That 500,000 ask was important. Thank you for bringing that to the floor. Have you spoken with the Department of Human Concerns on the increased costs that you guys are dealing with? And if so, have they mentioned, what did they say?
In fairness, I have not, no.
Okay. All right.
Yeah.
I know that you do other things besides Aloha House. You mentioned the foster family, you're involved in a lot, let's just say
Yeah.
that. So that 500,000 is only going to Aloha House? How about the other programs that you're working on? Do they need more funding as well?
I would say, other programs have different sources of funding. And I would say Aloha House, the delta that Councilmember Batangan mentioned is widening, right? And because there's medical services and the RN costs, it's substantially more than, the delta in other programs, which, we do pull in unrestricted funding, we do fundraising, we do, to get those smaller costs when there is a delta, to get those costs covered. But, with our detox, our residential program, it's just so costly. And it's a little bit different. So there's more of a sense of urgency there for me than our other programs.
Okay, thank you. The last thing I'll ask real quick, you mentioned in the beginning how when someone goes to the emergency room, then you grab them. But you said addiction, or they have to have an acute medical condition to stay there kind of explanation to me. Just trying to understand that. Does the hospital not think addiction is an acute medical condition? I mean, you can die from detoxing, right? I mean, I don't understand why they say, oh, well, we can't, you're not in our purview of ER. That doesn't make any sense.
Yeah, so if you have an existing medical condition that, so for example, a level of liver damage, or you have diabetes and it's out of control and you need to be stabilized, those are the kinds of, or hypertension, or, heart disease that, in addition to that, you have an alcohol use disorder or you have a substance use disorder. the hospital, if you're in a, the hospital has to treat, if those are a severe medical condition, then they cannot turn you away, right? They're gonna treat those medical
Okay,
conditions.
just alcohol.
But
just
if it's
alcoholism.
just alcohol, if you're coming into the ED and you have alcohol in your system, what we use is what's called a CWAS score. And depending on that CWAS score, if you need to be, what do you call when they give you the liquids? IV. If you need IV, if
Okay.
you need your stomach pumped or something, they're gonna have to do that for you. But once you're medically stable, that you don't need IV, maybe you still don't feel well, maybe you're vomiting, but that's not life or death. So we at Aloha House will take a CWAS score of 19 and below. 20 and above, you need to stay in the hospital. But for example, in Hilo, at the Hilo Medical, they will inpatient a score of 12 and above. So we feel, I think because we've been doing this work for so long, we're very confident and in what we're able to do, but other detox providers, I think, like I said, the level of medical detox that we provide is really unusual in the state.
Okay, thanks for that clarification. Thank you. Thank you, Chair.
Okay, mahalo, Vice Chair. Next, we have Member Rollins Fernandez, followed by Member Bolton.
Mahalo, Chair. Okay, just to follow up on the, I don't know, how you measure success, for the organization.
Yeah. For our organization? Okay. If I have I mean, honestly, like in this day and age, like success means like you're able to pay your bills. And that's probably like what's heaviest on my mind these days, especially in working with my board. Success is being able to pay our bills and keep these services in community. When you're working in behavioral health, it's hard to measure success, I think, by people that complete treatment, partially because like they're stepping down, like I said, every step they take in the right direction is a step to celebrate. But they may complete, like, let's say that I want to say 75% of our consumers complete residential treatment, right? But residential treatment has 24/7 monitoring, and we're really isolated, and you're not getting out into community. You're not around your friends and your family. You don't have the same temptations as you do once you get out into the outpatient. So then they go to outpatient, right? And if we can keep them in clean and sober, then we do, but still, right? You have all that, you have more free time. And we know what happens with idleness. So, I don't know our clean and sober, I don't have the data offhand of how many people are able to, actually stay within our program for a year, really complete Aloha House and move on to reintegrating in community. I don't have that offhand, but that for Aloha House, that would be the symbol of success, right?
Okay. Mahalo for that response. Mahalo, Chair.
Member Bolton.
Thank you, Chair. I know you said meth and fentanyl is definitely frequent flyers. Have you folks been able to get any of the money from the opioid settlement because it's not allowed?
No, it is allowed. We're a treatment center, so it's allowed. And I definitely have asked for money. I asked them for $500,000. I haven't heard back, but the money is sheltered with ADAD. The Alcohol and Drug Abuse Division. So it's funded a couple of their positions, and they have, an opioid department, or I don't know what it's called. And so they are funding at least a pilot that is starting here in Maui County that is also involved with the ED in trying to get people with opioid use disorder to who are not interested in coming to Aloha House. They don't want to get into care, to try and connect them with telehealth to get them on some kind of medication-assisted treatment.
Because
So,
last time we accepted opioid settlement money, it was under the prosecuting attorney's department, like 800 or something thousand. A lot of it, they said, we're going into the Narcan.
yeah.
Do you feel that it should be more split to a treatment center, or is the Narcan a good use of opioid settlement money? And do you think the police are doing enough to stop the flow of meth and fentanyl?
Well, I can't speak to what police do, that's for sure. I think it's important to have Narcan. When people are leaving us, we give them Narcan because it's life-saving. Having said that, it would be really great, and I have spoken to Andy Martin about wanting opioid settlement funding. So I think absolutely treatment centers should be included in the recipients of settlement funds. Especially, I mean, I think now is just, I mean, my presentation was stark, but that's because I feel that that's where we're at, right? Where there's a lot happening federally that can change. I mean, there's changes every single day, right? And
How come they're giving it to alcohol if opioid is different than alcohol, and the money for,
oh, what do you mean alcohol?
I thought you said some alcohol treatment positions were funded with the.
Oh, that's the Alcohol and Drug Abuse Division. So the settlement funding is with ADAD. So ADAD is a section of the Department of Health. And then ADAD holds the funding and is able to decide how to spend it. So they funded some positions, they're doing research, there's a pilot where they're trying to do some telehealth offer telehealth to the emergency departments to get users of, addiction, opioid, people addicted to opioids to agree to telehealth medication so that they don't overdose. And it's something that has been done nationally. I think that has, maybe they're piloting it because they think it can be helpful here. But I don't think it's gone to any treatment centers. And I do think it would be great if they did give us some of that opioid settlement funds. So I have asked for it.
Did Prosecutor Martin say why not?
He said he would talk to ADAD and put in a good word for us.
But that's money that the state holds. I think he accepted like 800,000 on behalf of the county to him.
Yeah, I don't know the timing. So probably I made an appeal for opioid settlement funds directly to the state and then followed up with Andy Martin this year, so in 2026. So I'm not sure when the timing on receiving funding and all of that. And
Chair, is it okay to ask Corp Counsel, when we accept or authorize the acceptance of the 800,000 of opioid settlement money, is it possible to condition it to a treatment center, portions of it, or we just have to accept the money?
And we can send correspondence from the committee.
Because, if we're accepting 800 something thousand, maybe 400 something can go to treatment centers and the other 400 can go to Narcans or something.
Or if Andy is having some kind of grant program for the money, I'm not sure. We can find out. Yeah.
Thank you.
Thank you, Member Polton. I just had one question for Acting Director Kraus. If she's online. Director Kraus. Oh, thanks for joining us this morning. I was just wondering, as far as payroll, when it comes to the county or the departments giving out funding for payroll, is that something that the department does, or we would have to follow certain guidelines?
Thank you, Chair Sinensi, for that question. The department does fund salary items for a majority of nonprofits that we issue grants to. So it is something we're used to seeing and can accommodate.
Okay, thank you for that answer. Thank you for joining us. Members, any other questions for Acting Director while she's up? Thank you. Okay, members, we have a second item, but we did want to mahalo Ms. Hokoana for being here and answering very diligent all of our questions. Mahalo for that. And with that, members, if there are no objections, I'll defer this item. Thank you. Oh, we have one more?
No, I just was, never mind. I see that it was uploaded to Granicus. Never mind.
Okay. Thank you, and thank you for joining us. Okay, members, our second item is the operational and budgetary review of the East Maui Water Authority. Today we have Director Young with us to provide a presentation on the authority's operational and budgetary review of the fiscal year 2026 budget. And at last week's BFED meeting, we talked about some of the smaller departments not having to come to the chambers. So this would be your opportunity if you had any questions for Director Young. Okay. Yep. Do we have her presentation? Morning, welcome. Welcome, Director Young. You have the floor and you can introduce your staff.
Oh, God. Okay, great. Oh, there we go. Okay. Thank you for the opportunity to present to you today. I really appreciate it. Staff is handing out our most recent, oh, I see you got it, our most recent newsletter. We're going to be doing that quarterly. Today, I'm going to give you a presentation just on our budget. And then we can go into questions afterwards. And I want to introduce, I brought with me our grant coordinator, Leslie Tamarabuchi, so she can answer questions about that. She's also been very useful with our strategic planning, and I'm gonna talk a little bit about our activity mapping that we've done. So you can go to the next slide. So fiscal year 2026 is our first year of full operations, so we're still creating the department. We're building capacity, and we really wanted to make sure that we had a strong foundation as we move forward. We're creating positions and hiring employees, and I can't emphasize enough how much work that is. And I know that you talk to Department of Personnel Services. They're extremely helpful, but it's a long process. One of my most recent positions was 41 steps in Workday, and the other one was 68 steps. They're helpful. It's a process that's already in place, and they provide a lot of guidance. It just takes a lot of time and effort to do that. We've been very intentional about going out to the community and learning from them, not just giving them information, but they're the ones that live in the area. We had 12 Meetings, 9 of them were part of our community conversations series. We had 2 field trips as a part of that. All of that leads into our strategic and operational planning. And then Leslie has been developing our incoming and our outgoing grant program. So now I'll kind of dive into more of the numbers with the next slide. We're still the smallest and the newest department, $1.2 million. Not a whole lot of money, but once you have staff, there's a lot of work that can be done with staff. I'll go through our A, B, and our C accounts in more detail too, so you can go to the next slide. Our salaries and wages, we have 9 employees. You can kind of see with the other newer departments where we're at. We're expanding just the way that they expanded too. To build capacity, you got to go at a rate that you can handle to make sure that you're really mentoring and training and bringing up your new employees. So the next slide. We have 8 staff positions, but 9 employees because 2 are half-time. Here's just a list of everybody that we have. Everybody's on board up, and we are in recruitment for our water resource specialist. If you look at the back of the newsletter, we've been doing a lot of recruitment to make sure that we get somebody for that. And then last year during council deliberations, we have field supervisor positions that were given for a couple months funding. So we're working with Department of Personnel Services on developing those positions. And the next slide. I wanted to show you just the timeline of our staffing, how we're growing. Last summer, it was really between June and September that we were able to bring on 3 people and train them as well. I just brought on a planner 2 who actually was out of college a year or 2 ago and wrote her senior honors thesis on East Maui water, so I felt very lucky to be able to bring her on board. Next, we hope in the next month or 2 to bring on the water resource program specialist. And then this is the organizational chart. Probably the most interesting thing about it is it shows 9 direct reports. I spend a lot of time with each of my employees. I meet with Leslie twice a week. I meet with everybody else at least once a week. It does take a lot of time organizationally with running the department, the administrative work on it. I'm hoping as time goes on that I can, normally you have 5 to 7 direct reports. I want to make sure I'm the one that's really training everybody. You can go on to the next. And then I want to talk about, we've been doing what's called activity mapping, and it's identifying all the things we're doing and all the things we're supposed to be doing. What you don't see, and you're not really meant to read all the details, but it shows you what they are, who's responsible, who's accountable, and what the timeline is. But for budget purposes, the most important thing is identifies your gaps and your budget inefficiencies. And we did this work as we were planning for for growing. And where these budget inefficiencies show up in terms of my budget is they show up, I don't have a lot of overtime, so they show up in CTO, they show up in staff just dedicating themselves. I want to make sure they don't get burned out. And it does show up in professional services where I can do that. I think that's a very inefficient way to provide services to a department where employees, when you're doing it because of lack of employee capacity. The communications and community engagement work also includes the policy work. The administrative work, which is the board management duties and administrative duties, a lot of those are done by the private secretary because we don't have a deputy director, we don't have an administrative officer, and that really does lead to kind of overload in those areas. Next slide. I'm going to go over operations in the B account, but